Hello everyone, this is a case of vault prolapse post-hysterectomy and I am doing a laparoscopic repair of the vault prolapse, laparoscopic Sacro Colpopexy. So after doing the port position and patient position, I am mobilizing the bowel a bit upwards so that our sacral promontory will be visualized. Now we use 50 cc syringe in the vagina. Now we are opening the posterior space. In this case, mainly the vault prolapse along with the cystocele was prominent and the rectocele and the enterocele component was very minimal. With the help of the shearer, I am dissecting the rectovaginal space. Now in this case, you can clearly see that with a bit and by bit dissection, I am opening this space. So this is an avascular space. So if we go carefully and slowly, we can open up the space without any bleeding. We have to make sure that vagina should not be opened up. So with my left hand, I am giving the traction, and with my right hand, I am trying to creating this space with the shearer. We will go deep down up to the floor of the pelvic floor, that is the levator ani muscle. So if there is an enterocele or a component of rectocele is much more prominent, then we have to fix the mesh at this joint. But in this case, as because the enterocele and the rectocele component was minimal, we are not planning to go until the levator ani. But still, we are dissecting the space as a routine procedure. Now you can see that space is well created. So that's my levator ani muscle on the right side. Now I am working on the right sided uterosacral ligament. I am cutting the peritoneum over the uterosacral so that when we will be making the posterior peritoneal cut, then we can join these two spaces. Some more dissection in the posterior space so that the mesh can fix easily. Now once we are finished with our posterior dissection, we move anteriorly. And we have to be very careful so that we should not injure the bladder. Sometimes the bladder is very much adherent with the vault and it's very difficult to get a plane. So with the traction on my left hand side, I am pulling the bladder upwards and creating the plane with my shearer. So in laparoscopy, air helps, then in pneumoperitoneum itself creates the plane, so you have to go in the correct plane. So the traction and counter traction plays an important role in laparoscopy. Now you can understand that already we have got a plane of bladder and the vagina. So I am guiding my shearer in between that plane and going slowly so that we will not injure the bladder. Also, you have to make sure that vagina should not be opened up. Otherwise, there will be very difficult in placing the mesh. In this case, as because the cystocele and the wall prolapse component was very prominent, so that we need at least 3 to 4 centimeter bladder down from the vagina, so that we can fix the mesh easily. So we have to dissect more bladder downwards. So now you can understand that bladder is almost separated from the apex of the vault, but we need another 2 to 3 centimeter bladder down more, so that we can fix the mesh easily on the upper part of the vagina also, so that the cystocele component will be corrected. So traction and counter traction plays a very important role. Like here, with the traction in my left hand device, I am getting an adequate plane. Now you can see that almost 3 centimeter of the anterior vaginal wall has been exposed from the bladder. So we have ample of space of fixation of the mesh in the anterior part of the vagina. And there is hardly any bleeding. Also a bit lateral dissection is being carried out for adequate fixation of the mesh. But overzealous dissection on the lateral side is not necessary. Now almost 4 to 5 centimeter area of the anterior vaginal wall has been exposed. That's an adequate for placement of the mesh. So once this anterior and the posterior dissection in the vagina has been created, then we will be going for our next step. that is dissection at the level of the sacral promontory. Here one thing, I have to be very careful that the dissection is being carried out on the right side, and so we have to be sure that we should not injure the right ureter here. Here we can identify just lateral to the peritoneal cut was the right ureter, and also at the level of the sacral promontory there are great vessels, the common iliacs, so we should not injure the common iliac. So with beat and beat by dissection, I am opening up the spaces, and at the level of the sacral promontory we will open up the anterior longitudinal ligament to which we will fix the mesh. Now this posterior cut, we join this cut with our incision on the posterior surface of the vault, so that it will be very easy for placement of the mesh. That's our ureter. We always look where our ureter is and be very careful so that we will not injure the ureter. So traction and counter traction is very important in laparoscopy to identify the champagne glass plane. That is the last joining point. Once this is cut, all these spaces are joined together. Now we can identify this white glistening structure, that's the anterior longitudinal ligament at the level of the sacral promontory. After that, we have inserted our polypropylene mesh. We have cut the mesh into the Y shape. So one arm of the mesh will be in the posterior part of the vagina, in between the rectum and the posterior vaginal wall, the space we have created. Another arm will be anteriorly between the bladder and the vagina. So now I am fixing the mesh anteriorly in my anterior vaginal wall. We are using here 10 proline suture for this fixation. So usually we take 3 or 4 proline stitches anteriorly. Here we can see that already 3 stitches has been taken, and this is at that level, that was anteriorly. Now we are fixing on the top of the vault. So once that is done, we are moving posteriorly at the level of the sacral promontory. Usually we use tacker, but in this particular case we are using the sutures. So a very deep bite has to be taken so that the anterior longitudinal ligament is pierced, otherwise the mesh will not be fixed here. But we have to be very cautious so that we will not injure any great vessel during this stitch. So we are taking the second suture here at the level of the anterior longitudinal ligament. Usually 2 sutures are fine enough, or we can use a tacker device. In that case we use 2 or 3 tackers. So once the mesh is fixed, the mesh has to be retroperitonealized, otherwise bowel will adhere and there will be disastrous complication. So we are closing this peritoneal drain with the help of the 3-0 vicryl here. So usually we close this in a running fashion, so a continuous suture will be taken with the help of the 3-0 vicryl, so that the entire mesh will be retroperitonealized. And one more thing, during the fixation of the mesh should not be tightened very tightly, otherwise patient will have very much postoperative pain, especially in the rectum and during fixation. So the length of the mesh should be adequate enough, not very loose, not very tight. Usually fibrosis will take place and that will take care of the prolapse. During this peritoneal closure, we also have to take care that we are not taking bite through the ureter, as because the right side ureter is very close to this rent. Now you can see that the mesh is getting retroperitonealized. The last part remaining, the anterior and the posterior part is joined. The whole of the mesh is being retroperitonealized. If there is a rectocele or enterocele, we usually fix the mesh posteriorly, but if that component is absent, we only place the mesh posteriorly but don't fix it. So here in this case also, we place the mesh posteriorly but we have not fixed it. So we fix the mesh anteriorly in the anterior vaginal wall, also at the apex of the vault and at the sacral promontory. As because in this case the enterocele and rectocele component was very minimal, mainly the cystocele and the vault prolapse. And you can see that the last knot is being done, so all the mesh is being retroperitonealized. So once suture is finished, suture is taken out. So thank you all for watching this video.